Hello and welcome back to Dr. Carri's Clinical Corner. Today we're going to talk about prolapse. So what prolapse feels like. Most people, they feel like there's pressure in the pelvis or heaviness or feels like something's going to fall out of your vagina. That's usually what people explain it like. So it's not pain, but that's like the most common symptom. So what is it? It's when the organs in the pelvis are a little bit lower in the pelvis than originally. So often this is common in pregnancy, in vaginal childbirth, or sometimes my patients who have chronic constipation can get it. So let me try to show you a couple ways to explain it. So this mostly happens to females, people with vaginas, not super common in males. And so these are your organs, representative, your bladder, your uterus, and the rectum. And they sit in the pelvis. So here's the pelvis, pelvic floor. They sit in here nice and snug. And then what happens is if you feel like, here's the vaginal opening. This is clearly not anatomically correct, but it kind of feels like things start coming out. It's a little hard to show. So normally it's like it should be all inside, and then it feels like things start to come out, or this starts to, your cervix, uterus starts to come out, or the rectum sort of like forms a pocket into the vagina. That's a prolapse. Another example is this little chicken. And it feels like boop, things are coming out. So there's 4 grades to a prolapse. Okay, so this is the most important part. Grades 1 and 2 mean things are a little bit lower, but they're still all inside the pelvis. Grades 3 and 4 mean things are coming out. Like this is a grade 3 or 4. Okay, like it's falling out of the bottom. And most commonly, I see grades 1 and 2, so they're just a little bit lower, but all well within the pelvis. So what's happening is our organs are suspended from above by ligaments. And so if you think of that chronic downward pressure into the pelvis, so think about like a long pushing stage of labor, of childbirth, it kind of stretches the ligaments. So prolapse is kind of weird. We can't anatomically reverse and make those ligaments shrink without doing surgery. But most people that have grade 1 or 2, it gets better. Their symptoms get better with either time or physical therapy, or there's something called a pessary. That's like a internal support. There's lots of external supports you can get, like certain compression underwear or these like belts, kind of like, they call them like female jock straps to kind of like hold everything in or give it pressure to hold in. So most commonly people are going to get grade 1 or 2, just things are a little bit stretched out, a little bit lower. Grade 3 and 4 means one of those ligaments probably is broken, and it's not holding the bladder or the uterus or the rectum up. And so that probably requires surgery. We cannot redo the ligament. We can't shrink the ligaments back with physical therapy, but by sort of creating a better environment for inside the pelvis, most people's symptoms go away. So what do we do in physical therapy? We assess the pelvic floor muscles and we figure out, is there tightness? Is there weakness? So for a long time, the theory was we got to tighten these muscles to support from below. But when we think about the anatomy and how the organs are suspended from ligaments above, we don't necessarily need to tighten this. It's not going to necessarily help. But now we sort of think, as of the 2020s, 2024, I went to a class in 2018, I think, and this was kind of the theory around that time, is that maybe there's tightness in these muscles. So I sort of think of it as like, if things are lower in the pelvis and the muscles are tight, then like everything's gonna be like pushing on this and gonna feel uncomfortable. But if we can create more space, then these can just sort of live in their new home more comfortably. So we assess, sometimes it's weakness, sometimes it's tightness, sometimes it's both, and we just treat what we find. Also, for a lot of my patients that have prolapse symptoms, strengthening their hips, strengthening their legs also helps them. Another thing, so often I see this in new moms and I see it in menopause. So these are hormonal changes. So when estrogen is low, which is what happens in breastfeeding and in menopause, our vaginal tissues have estrogen receptors in those skin tissues. And so when estrogen is low, the labia, the outside support, is thinner, also drier. But sometimes getting an estrogen cream, so it's localized only, it's not systemic. It does not have a negative impact on breast cancer. Should be safe for breast cancer survivors, but that's between you and your doctor. But it's localized hormones that just sort of thicken up these tissues and give more support. So that's something I recommend if people don't get better with just exercise. And then also you can get what's called a pessary. So it's like an internal support, and there's a whole variety of them. The most common is like a ring pessary. So it just sort of like goes in and like supports under the bladder or under the uterus and kind of holds them up. And some of my patients, they need a pessary for a time. Maybe they just need it when they exercise, or if they're like traveling and walking a lot or on their feet a lot, or if they're a nurse, they have a job where they're on their feet a lot. But a lot of times people can wean off of it, so it doesn't mean you need a pessary forever. But sometimes a pessary can really help physical therapy, because if these muscles are stretched out because there's always pressure from above, then it makes the muscles weaker. So if we can support the organs from the inside into a better position, we can strengthen the muscles around that better. So sometimes we need a combination. And then sort of the last resort, or the highest level of intervention, is surgery, where they go in and they resuspend the ligaments of the organ, so it's like now in a better place. But again, generally only people that need that are like grades 3 and 4, where it's literally coming out. And I can tell you, in my career of almost 20 years, I've seen one bladder prolapse that was like a grade 3 or 4, and like, you will know, the poor woman could not even sit. So imagine this, like every time she's up, this is out, so she can't sit comfortably. And for her, I mean, she was in her 80s, so I don't know what she decided to do, but she's the only one that I would say like, you need surgery. For everyone else, like again, most people that come to my clinic are grade 1 or 2. It's still well within the pelvis, and we can optimize the pelvic floor muscles. We can strengthen the hip muscles surrounding it. You could get vaginal estrogen. You could get a pessary. There's a lot of less invasive things to do. And in my experience, people that get surgery, it helps for a time, but over time, sort of the symptoms come back, and from a physical therapy perspective, we sort of think like we didn't, so they did the surgery to resuspend the ligaments, but they didn't change the environment. They didn't change people, how their pelvic floor muscles are working. So another thing people ask, because again, I think doctors are like, you cannot lift heavy weights, right? And I've had some competitive weightlifters who get prolapse symptoms, and they're not correlated. So I teach my patients in the clinic, if you want to lift weights, if you want to exercise, let's figure out how to do that. And it's much simpler than you think. So yeah, even I've had like competitive weightlifters who have done fine. I was going to say, unless you're like max lifting, but even if you are, like you can do it. So oftentimes it's sort of like what's happening up above the pelvis. So I like to work a lot on breathing, on coordinating the pelvic floor with the abs. So here's sort of another example. This canister. So like, let's say you're really like holding your breath, tightening your abs, then your pelvic floor is like the weak spot, right? It can't handle the pressure from above. So then you're going to have a prolapse, you're going to have bladder leakage, something else. So that's sort of like if we can work on the breathing, the coordination between your abs and your pelvic floor, then oftentimes you can lift heavy weights. It's fine. So the one thing I tell people, don't hold your breath when you exercise, and if for people who want to lift heavy weights, you still should be breathing unless you're doing like a 1 rep max. You still should be breathing. Like if you're lifting heavy weights where you're getting to like a lot of weight near your 1 rep max, competition level, then there's some different breathing strategies and bracing strategies you need for lifting weights, but the majority of us are not anywhere near that. So we can practice better breathing, better bracing. Another thing I see sometimes is how people brace their core. It actually is putting pressure down. So if we can learn to brace the core in a more cylindrical way, right? I think of this. We want to brace into this, not brace down. So, a lot of times, like for heavy weightlifters, they'll teach them, like if they're wearing a belt, a back brace belt, they'll teach them like breathe into the belt to create stability. So that's for like the high level. Your everyday person that's going to the gym, even high level athletes, are not lifting that heavy of weights. So in general, breathe when you exercise, don't hold your breath, because that's gonna then direct the pressure. So if we are breathing, then we can change the canister and it's gonna go this way, and it doesn't really have an effect when we go in the upward direction, versus if we go in the downward direction, boop, everything opens up, right? So those are just some things that can help. One last thing I want to say about rectal prolapse. So a rectal prolapse mostly is the rectum sort of coming into the vagina. So it's a little bit hard to see in this model, but the rectum is coming in here. And what happens is, I should have made a drawing, but it kind of makes a like U-shaped pocket into the vagina. So normally the rectum, when we poop, the anus opens and poop flows out. But a rectal prolapse creates a little pocket, and then sometimes the poop gets stuck there, or it's hard to like push past that. So sometimes people need to use their hands kind of in the vagina to help that out. The rectal prolapse is a little trickier, but some of my patients, I've had success. I just tell them to use a squatty potty, like elevate their legs. So in nature, in history, and in some places in the world still, you squat to pee and poop, because in that position, your pelvic floor is the most open, the widest. And so the squatty potty, it's like Western style. We still want to sit and be comfortable, but we're raising our knees up, so it kind of opens up the pelvis. So some of my patients, like just changing the position they have on the toilet, they can poop better. Even with a rectal prolapse, that's kind of like making a little pocket in the vagina. You can also have a rectal prolapse into the rectum, but I think that's pretty uncommon, maybe with like severe chronic constipation, or with people that are having like aggressive anal sex. Those are kind of the only scenarios, but it's not super common. Most likely I see in my females, it's bladder prolapse, it's uterine prolapse, or like a little tiny bit of pocket of the rectum into the vagina. So there's a lot of things you can do before surgery. So if you feel like things are falling out, see a pelvic floor therapist, get assessed, and figure out what you need to do to support your pelvic floor. And then think about the other things too. You could get a pessary. You could get an external support garment like special underwear or special belts. I'll try to link some below. Yeah, but there's a lot of options before surgery. And I would say, even if you're going to do surgery, see a pelvic floor therapist, because then we can optimize how your muscles are working, how your coordination, things like that, so that it doesn't come back. The surgery, it just fixes the anatomy, but if how you're functioning and using that part of your body is not optimal and it's going to keep creating more pressure, then we can help with that. Another thing I tell people is like, try not to be constipated. So obviously some of my people, like, constipation is why they have issues, right? They have IBS, they have Crohn's disease, they have other sort of gut health issues, super common. But control your bowels as much as you can, because that constant pushing, right? Also, I try to teach people, if they have constipation, to, just like with exercising or weightlifting, to exhale as you poop, right? So don't try to bear down, because again, if we close the mouth, all the pressure goes down, and not necessarily in a good way. Same thing I teach my moms, if they come in during pregnancy, of how to give birth, is try to like exhale as you push. That way it's not excessive pressure on your pelvic floor. So I hope that helps. There is help for your prolapse without surgery, and be careful what you Google, because you're going to see the worst of the worst, but it doesn't always have to be that bad, and majority of people that I see, it goes away, their symptoms go away over time.